Hello and welcome. My name is Troy Seelhammer. I'm assistant professor in the Department of Anesthesia and Critical Care at the Mayo Clinic in Rochester, Minnesota, and I also serve as medical director at our program. Dr. Hamzah is assistant professor in the Department of Pediatrics and Critical Care at the Cleveland Clinic. Today, we're going to have an opportunity to discuss hemostatic activation in ECMO patients and how this predisposes to thrombotic deposition, embolic, and hemorrhagic complications. We're also going to be able to have some time to discuss conventional unfractionated heparin-based anticoagulation, as well as more contemporary approaches with direct thrombin inhibitors, more specifically bivalirudin. I don't have any financial disclosures today, although I should note that we will be discussing bivalirudin administration in ECMO patients, and although it has FDA approval for other indications, it does not carry approval for this particular use pattern. Dr. Hamzah also has no financial disclosures today. To get things started, Dr. Hamzah will frame the conversation by spending some time discussing background, hemostatic cascades, etc.
In the first part of this talk, I'll go briefly over the use of ECMO, the basis of hemostasis, and the need for systemic anticoagulation while on ECMO. ECMO is the last resort support for refractory cardiogenic or respiratory failure. The number of ECMO centers and the number of ECMO runs are on the rise. As you can see from the ELSO registry data here, the number of ECMO centers has increased from 50 to 400, and the number of ECMO runs have an annual growth rate of 17% over the last decades. One of the predominant challenges that face us as clinicians at the bedside when we take care of ECMO patients is that clinical challenge of facilitating appropriate clot formation while avoiding thrombotic complications. So you want to have the patient be able to maintain hemostasis, prevent bleeding, minimize transfusion. Also, you want to prevent thrombus formation and fibrous deposition and platelet aggregation in the circuits. So again, from the patient perspective, the goal is to maximize hemostasis, minimize autologous blood product transfusion. And this task will be challenged because of the necessity from the circuit perspective to minimize the platelet activation and the fibrin deposition. So let's take a step back to understand the role of the endothelium in maintaining hemostasis and anticoagulation. Under normal conditions, the body is in anticoagulant state. It's geared toward keeping the blood flowing through the vessels and the capillaries to keep oxygen delivery to various organs. And this is done because of the endothelium, which is actually the largest organ in the human body. The endothelial cells plays a critical role in maintaining hemostasis. If you look at the several mechanisms this is done, the endothelial cells provide that smooth, non-thrombogenic surface. Endothelial cells will secrete nitric oxide and synthesize prostacyclin, and both are important in inhibiting platelet aggregation. Endothelial cells will secrete heparin-like molecules, which will bind antithrombin 3 and inhibit thrombin. They also will express thrombomodulin, which, as its name implies, it will modulate thrombin and inhibit clot formation. For all these factors, under normal circumstances, the body is most likely in an anticoagulant state. But when you have illness, you have trauma, you have injury, that balance between procoagulant and anticoagulants probably sway toward the procoagulant factors. And this is actually a protective to prevent, if in case of trauma or injury, to prevent patients from bleeding and be able to make clot formation. So now you have a critically ill patient who is placed on ECMO. He's already in a procoagulant state, and you add a large surface area of non-endothelialized surface, which is the ECMO circuit, including the pump, the tubing, the membrane oxygenator. All this will lead to the immediate activation of the coagulation and the inflammatory systems. So as the blood is flowing through the ECMO circuit, it experiences high shear forces in the pump and the cannulas. The blood is exposed to artificial surfaces, will activate cellular, hemostatic, fibrinolytic complement systems. So the moment the blood is in contact with the ECMO tube, there is protein adsorption, which will induce platelet aggregation and thrombus formation. There is also factor 12 adsorption and activation and autoactivation, which will, by factor 12 activated, will convert pre-kallikrein to kallikrein, which will start the coagulation cascade and thrombin generation. So as thrombin is formed, also it will promote platelet activation. The platelet aggregates deposited on the surface. They are stabilized by fibrin strands to form that platelet fibrin thrombus. So a study that was done using multi-detector computed tomography with 3-dimensional post-processing to quantify the thrombus burden in the membrane oxygenator. And you can see here, there's thrombus formation in the membrane oxygenator that can be detected using this technology. And what's important also in that, using this technology, they were able to detect thrombus burden in all ECMO circuits that were in that study. So despite optimal anticoagulation, there was thrombus formation that's already in fibrin depositions. So with the current technology in ECMO, systemic anticoagulation is needed to prevent circuit thrombosis. And when you are using the systemic anticoagulation, heparin, bivalirudin, you want to find that dose range that will prevent thrombus formation, fibrin deposition, and will also allow the body to make clots when needed, so it can prevent bleeding and blood product transfusion. Because in pediatric ECMO, this was a large multi-center study that done with Dalton and colleagues, found that bleeding events are present 60%, thrombotic events are present over 30% of the patients. And both bleeding events and thrombotic events are independently associated with mortality. So in an attempt to mimic the endothelium, the idea of surface modification of the ECMO circuits came in place, aiming to overcome the blood biomaterial surface interaction, modifying the hydrophilicity, the hydrophobicity of the polymer surface, coating the circuit with substances that will mimic the endothelium or will have antithrombotic agents bonding to the circuits. This surface modification can be classified into 3 major groups: biomimetic surfaces such as heparin, nitric oxide releasing, direct thrombin inhibitors, bonded circuits. The biopassive surfaces, where albumin, phosphorylcholine is on the circuit surface. The third one, which is the endothelialization of the blood contacting surface in the ECMO circuits. In the table on the upper left side here, you can see the different types of commercially available circuits that will have heparin bonding, albumin, phosphorylcholine, etc. Here in this graph, you can see the effect of nitric oxide releasing circuits on animal models of ECMO, where the box here are showing circuits with nitric oxide releasing characteristics, where there was mild decrease in the platelet count from baseline versus the conventional ECMO circuits. And under microscopy, there was less platelet aggregation in those nitric oxide releasing circuits versus the conventional circuits. So definitely these novel technologies are promising, and in the future may help to minimize the need of a high dose of systemic anticoagulation. So in order to go to the basics of hemostasis. The first step of hemostasis is the platelet plug formation, and it involves 4 steps: adhesion, aggregation, swelling, and maturation. The first step of thrombosis or clot formation is the platelet plug formation. In the adhesion phase, you know that platelet glycoprotein 1p receptor binding to the exposed subendothelial surface mediated by the von Willebrand factors. In the aggregation phase, there is vasoconstriction that's mediated by the activated platelet, which synthesize thromboxane A2 by the use of cyclooxygenase enzymes. And we know that aspirin will inhibit these enzymes and will decrease the platelet aggregation. In the third step, in the platelet plug formation, the swelling phase, where there's interplatelet binding via the fibrinogen cross-links to the glycoprotein 2b and 3a receptors on the platelet membrane. And this is the end of the bleeding time test. And although the clot is formed, it's still unstable and can be easily disrupted. So the fourth phase is maturation, where the fibrinogen is converted to fibrin with cross-linking to strengthen the blood. Calcium also will strengthen the blood platelet plug. Under electron microscopy, you can see a discoid platelet that start to form membrane tethering during the adhesion to the von Willebrand factor. And in image 2, you can see platelet aggregates start to form with the help of formation of the adhesion contact between the discoid platelets together through the membrane tethers, which is the arrow showing you this membrane tethers. In the third stage, there is a reversible aggregation of the discoid platelets. You can note in this image, there is a cluster of platelets that are surrounding a single activated, central activated platelet through the development of the membrane tethers. And the fourth stage, there is a development of the stable plug. There is the that change in the platelet morphology, the membrane tethers, the fibrin strands start to develop and stabilize that platelet plug. So this is the first step of clot formation, is the platelet plug formation. The second step, or secondary hemostasis, this will be an overview of the coagulation cascade. As evidence from the preceding several slides, it's very important to understand the basics of this cascade, especially in patients on ECMO. So these coagulation cascades may involve over 30 proteins. In summary, all these will lead to conversion of soluble fibrinogen to insoluble fibrin. There is an extrinsic pathway, there is an intrinsic pathway. There is an extrinsic pathway, which eventually will lead to the formation or generation of activated factor 10. There is intrinsic pathway, which will lead to the amplification of factor 10A generation. So one molecule of factor 10A will catalyze the formation of approximately 1,000 thrombin molecules. And thrombin is a serine protease that plays a crucial role in the coagulation cascade and the generation and stabilization of the clot, as we mentioned before, by conversion of the soluble fibrinogen to the insoluble fibrin. The thrombin contains 3 binding sites that are essential to its coagulant and thereby anticoagulant activity. There is a catalytic site, the exosite 1, the exosite 2. And eventually, after the secondary hemostasis, you have the platelet plug formation, you have the fibrin strands, and stabilization of that clot is happening. So ECMO in general is a classic example of contact phase activation. So systemic anticoagulation is necessary to prevent thrombin generation. It is also very important when you choose the anticoagulation strategy to consider the patient-specific factors, which will impact the timing of the initiation of the anticoagulation, the dose that you're gonna start with the level of anticoagulation you want to attain. These patient-specific factors will impact your plan. There is no one size that fits all. So there is a great difference between anticoagulation strategy for someone on VV ECMO versus VE ECMO versus post-cardiotomy ECMO. And other patient-specific factors that you have to consider if the patient has renal insufficiency, if the patient is on dialysis. This may impact the clearance of the drugs that you may use for systemic anticoagulation. Also, if the patient is in sepsis, has thrombotic, easy to make thrombosis. So as you can see, there are different patient-specific factors that you want to consider before choosing your systemic anticoagulation. This will end the first part of this talk. So we went over the introduction to hemostasis and overview of the general principle of systemic anticoagulation while ECMO.
Thank you, Dr. Hamzah. Now we're going to change gears and we're going to focus in on the administration of systemic anticoagulant therapies. To get things... Thank you, Dr. Hamzah. Now we're going to change gears and we're going to focus on the systemic administration of anticoagulant therapy. When you conceptualize an ideal anticoagulant, it's important to think about all the varying competing factors. First and foremost, you need this drug to be effective in quieting down these hemostatic cascades. Ideally, you'd want this agent to be direct acting and not contingent upon the presence of a second anticoagulant or protein to have its clinical effect. You'd want this to be titratable with an anticipatable dose response curve with a reliable anticipated degree and intensity of anticoagulation that you can achieve in a broad array of pathophysiologic states. You'd want this drug to have an available reversal agent. And if it's not able to be antagonized with a targeted therapy, perhaps a half-life that's short enough where a reversal agent isn't actually necessary. And the reason why this is so important is because ECMO patients, as you're all familiar with, frequently have to proceed to the operating room or have even just invasive procedures such as lines, chest tubes, interventional radiology, tracheostomies placed. And so you need to be able to turn these drugs on and off with some degree of fidelity. If you could achieve delicate balance of all three of these competing needs, this would be an ideal drug. And unfortunately, this does not yet exist. If you have to think about what we currently have available, many will think about unfractionated heparin. And the reason why this is thought of first and foremost is because it remains the gold standard. It's the gold standard because it's widely available. It has the broadest array of available evidence to support its use. It's cost effective and inexpensive, and we've got a battery of laboratory assays to help to titrate this agent at the bedside. It's worth noting, though, that heparin is not a direct anticoagulant. It requires the presence of a second protein, antithrombin or antithrombin 3. You'll see both of these terms tossed around in the literature. And the way this drug works is to bind to and then upregulate the action of antithrombin by several thousand-fold. Fortunately, this takes place very quickly within an effectively near immediate onset of action. The half-life is variable, particularly when a lot of the tissues are saturated with circulating exogenous heparin, but more typically the half-life is around 30 to 90 minutes. The administration of protamine causes a chemical binding that immediately reverses the action of heparin. And so it does have that antidote or reversal therapy. Just for a visual representation of the pathway here, and you've seen this pathway earlier in Dr. Hamzah's portion of the talk. The way that this drug works is it binds to antithrombin 3 and it acts at two proteins, factor 10A and thrombin. And acting at these two sites, it dramatically decreases the ability for thrombin to cleave fibrinogen into insoluble fibrin. And by doing so, it downregulates the hemostatic cascade. As far as getting therapeutic with unfractionated heparin, it sort of depends on how you're approaching ECMO initiation. For peripheral cannulation, typically a modest bolus is all that's required, and this is administered certainly before you place your cannulas, but after probably gaining access to your peripheral sites. For post-cardiotomy ECMO, these patients are typically already heparinized. They're in an operating room and full heparinization has been achieved. And so actually to initiate systemic administration of heparin for ECMO, you oftentimes want to allow a portion of this systemic effect to clear on its own, or even small down-titrated doses of protamine to antagonize this heparin effect, because that degree of intensity of systemic anticoagulation can predispose to hemorrhage. There's also residual effects of cardiopulmonary bypass, and this includes quantitative and qualitative deficiencies in platelet function, as well as all the other zymogen precursors that are very commonly relatively deficient in patients having just undergone cardiac surgery. And so at most centers, and this is our practice at the Mayo Clinic as well, we typically do not initiate systemic anticoagulation with a heparin-based therapy in the first 12 to 24 hours. It's worth noting that heparin has a broad array of maintenance dose, and this is for a variety of reasons. One of these is a change in dynamic effect of sensitivity, and this is thought to be at least in part related to fluctuating levels of antithrombin. We know that in patients who have prolonged illness, particularly sepsis and critical illness that is sustained over many days, perhaps even weeks, there's a gradual deterioration in the presence of antithrombin. If you look at ECMO patients specifically, it's known that within 24 to 72 hours, at least 60% of ECMO patients will have a reduction in antithrombin below 70% normal. Additionally, there's fluctuations in sensitivity, and this isn't specifically related to heparin. It may actually be related to other things, including fluctuating platelet counts and other zymogen precursors that may be secondarily deficient. This is a slide now several decades old, but what it looks at looks at two different formulations of unfractionated heparin. One derived from the porcine or pig, and the other bovine. And what I wanted to draw your attention to is the amount of impact or potency of these compounds differs. Even individual lots can differ. And so if you look at these two compounds, on the upper one, porcine, there is a greater degree of potency when compared to bovine, both in the anti-10A activity, if that's the assay of your choice, or APTT. They also differ in their molecular weight. And all this taken together just means that there's continuous need for adjustments in unfractionated heparin dosing. This isn't unique to ECMO patients. This is true really for nearly all patients receiving this compound, but it's particularly essential for mechanical circulatory support patients because of their predisposition to both thrombotic laydown, embolic effects, and also, of course, hemorrhage. This is a bit of a busy slide, and I want to draw your attention to a few things here. First, on the top, this is looking at assays and their advantages and disadvantages. And if you looked at activated clotting time, or ACT, this is really most useful when heparin levels are quite high. And this is what we use during cardiopulmonary bypass. But it can be prolonged by a lot of different things, including hypothermia, reduced concentrations of a variety of zymogen precursors, including fibrinogen, and then platelet dysfunction, or even just relatively low quantity of circulating platelets. If you looked at APTT, this is a little bit different. It's really not specific to heparin itself, and it too can be prolonged by a variety of different variables. Now you have to also consider the lupus anticoagulant effect, and then of course, the expected decreases in circulating zymogen precursors. If you look at anti-10A, this is a functionally very different assay, and it's not nearly as influenced by coagulopathy, thrombocytopenia, or dilution, which is a very big advantage of this particular assay. And many centers are transitioning to anti-10A-based heparin titration protocols. But it can still be affected by hyperlipidemia and gross elevations in bilirubin, which unfortunately is common, particularly in cardiogenic shock patients and post-cardiotomy patients. So if you had to sort of summarize the limitations of heparin, it's this unpredictable and fairly long half-life, at least 60 to 90 minutes, and it can be markedly longer than that when the peripheral stores are saturated. It has a very unpredictable dose response curve, forcing you to start low and work your way up, which means higher number of dose adjustments and a greater amount of time to achieve therapeutic range. And you'll see later on in this presentation that direct thrombin inhibitors certainly have at least promise of an advantage here with achievement of systemic coagulation intensity goals more quickly. Heparin resistance is a known phenomenon. There's both congenital reasons for this and also acquired reasons, and this is oftentimes thought to be secondary to reductions in antithrombin levels. Heparin-induced thrombocytopenia is unfortunately common in mechanical circulatory support patients, and this is because many have multiple exposures to heparin, and also the sustained administration of heparin certainly predisposes to both type 1 and type 2 heparin-induced thrombocytopenia. This is a very challenging clinical condition to handle once it manifests, and certainly is an indication for direct thrombin inhibitor-based therapy, which all of these words and all this talk thus far leads you with a lot of questions, and really what else can be considered. We've alluded to this numerous times during this presentation, and what we're talking about here is a more contemporary approach using direct thrombin inhibitors. If you had to compare how direct thrombin inhibitors are different, I think it's useful to line them up side by side with what we've already discussed, heparin and antithrombin. Looking specifically at heparin, it's important to recognize that there's a wide dose response curve here. It is a component of hepatic metabolism and some renal clearance, and really requires a lot of careful titration to achieve and maintain therapeutic range. It doesn't act directly, and so you need to constantly think about and at least consider heparin resistance. This may be related to changes in clearance or differences in potency between lots, but more commonly, it's actually related to fluctuating levels of antithrombin. As I alluded to earlier, it is quite common within the first 24 to 72 hours to have what we think is clinically significant decreases in antithrombin activity. Unfortunately, it's not nearly as known or certainly as established that antithrombin replacement therapy offers any clinical advantage. And certainly there are studies in support of antithrombin replacement and many studies that suggest that actually harm may be caused by its administration. Bivalirudin is functionally different. I've got some slides to depict its pharmacologic, pharmacodynamic properties just coming up here, but I wanted to line up bivalirudin specifically next to argatroban so that you can compare the two side by side. And in my view, one of the most important things to recognize is that bivalirudin is metabolized differently. It's really not organ dependent for the bulk of its metabolism, and only maybe 20 to 25% is dependent upon renal metabolism and clearance. And so you don't have to worry about the liver, which is unfortunately something you have to consider with argatroban-based therapy. The half-life for argatroban is approximately twice as long as for bivalirudin. Neither drug has an antidote, and so that differing half-life becomes clinically significant in many settings. It's also worth thinking that although we have very good ways of assessing estimated kidney function and actually hepatic synthetic function and leakage of hepatic enzymes, we don't have a very good way of ascribing the metabolic capabilities of the liver, particularly in settings where it's dynamically changing over time. And unfortunately for ECMO patients, both VA and VV, there's a lot of reasons that the hepatic function can fluctuate in real time, markedly impacting the metabolism of argatroban-based therapy. So for the rest of the presentation, we're going to focus in on bivalirudin. It has a larger body of evidence to support its use in mechanical circulatory support patients, and the literature is maturing fairly quickly here, as you'll see in a couple of slides. The way this drug works is it's a bivalent inhibitor of thrombin. It acts directly, no other protein. You don't have to worry about antithrombin, and it binds to and aggressively shuts down the action of thrombin. And remember, thrombin is what's essential for that cleavage of soluble fibrinogen into insoluble fibrin. And so you can actually shut down the creation of fibrin monomers. It acts to circulating thrombin, but also at bound sites of existing clots. And this is what many authors describe as a key functional advantage of direct thrombin inhibitors. Notice here that there's arrows depicting the action at the bound site, but also the circulating site. I think this is very, very important. It's underappreciated, but it has a growing recognition of one of the clinical advantages of bivalirudin or direct thrombin inhibitor-based therapies, as all direct thrombin inhibitors have this unique property. Its onset time is immediate. You can use this agent for ECMO initiation, although it's rarely done in that fashion. It has a short half-life of approximately 25 minutes, assuming normal renal function. And about 80% of its effect is organ-independent metabolism through blood proteases. This same slide I showed you earlier, and Dr. Hamzah outlined earlier in his portion as well. Now you can see the action of bivalirudin. No second protein acts directly at thrombin to shut down the cleavage of fibrinogen into fibrin. 20% of this compound is cleared through the kidneys, and that means that if you do have particularly more severe acute kidney injury or severe chronic kidney disease, perhaps dialysis dependence at baseline, or you're pausing or initiating renal replacement therapy, you need to think about adjusting your bivalirudin dosing. This seems to be something that would cause a lot of complication and clinical challenge. And in actuality, if you can develop robust titration protocols, it ends up being quite readily managed. As far as monitoring bivalirudin anticoagulant intensity, APTT is by far the most commonly employed assay. Typically, the goal range reflects that of heparin-based anticoagulation for full intensity, 60 to 80 seconds. And for reduced intensity, perhaps veno-venous ECMO, more 40 to 60 seconds for your APTT. There are other assays that are available. ACT has a place, particularly if you need a rapid check. But the body of evidence for these long-term ECMO patients and the sustained titration of bivalirudin-based therapy is less robust for ACT. Eccrine clotting time is unique to bivalirudin, but it's not widely available. In the future, perhaps chromogenic anti-2A will be of greater use, but again, something that is used really for primarily research purposes at this point. Touching on its advantages over heparin, I think one of the most important things is this ability, as I alluded to earlier, of acting at sites of clots. Now, all patients on sustained periods of mechanical circulatory support will have laydown on their circuit. It typically causes or occurs at points of turbulence within the blood flow path as it moves through the extracorporeal circuit. There's oftentimes laydown on the oxygenator and the post-oxygenator faceplates and in the tubing itself, particularly if there's periods of acute angle or stenosis in your cannula tubing. That turbulence activates primary and secondary hemostasis. Once that deposition occurs with heparin-based therapy, that causes further exacerbation of further clot propagation. For direct thrombin inhibitor-based therapy, because it can act at these local sites of deposition, it can actually facilitate the gradual natural dissolution of this clot over time. And we see this clinically at the bedside. It acts independent of antithrombin, which makes its dose response curve a bit more predictable. It has no effect on platelet factor 4. So not only is it safe in heparin-induced thrombocytopenia, it's clinically indicated. Thus far, as far as the literature goes, it's still maturing, but fortunately, the robustness of the literature is stabilizing quite quickly. And we're getting to the point now where there seems to be a lot of promise for direct thrombin inhibitor, specifically bivalirudin-based therapy in ECMO patients. The available evidence dates back to 2009, and the first report was, of course, a case report, a 71-year-old post-cardiotomy patient who was HIT positive, and ACT was used to help titrate bivalirudin in this patient, and this patient fortunately actually survived this encounter with extracorporeal support. Dr. Ranuzzi et al. Really lit the fire for broader adoption of bivalirudin-based therapy. And what he did is perform a retrospective analysis of 8 consecutive heparin-based veno-arterial ECMO patients, followed by 13 consecutive bivalirudin-based veno-arterial ECMO patients. And what he found is a reduction in laboratory assay frequency in the bivalirudin cohort, and also a reduction in blood loss and a secondary reduction in the requirement for allogeneic transfusion of blood products. And taken together, despite the gross increase in cost of bivalirudin versus unfractionated heparin, there was an overall reduced cost of administration of systemic anticoagulation therapy in this population. And this is actually really, really interesting, and we'll touch on this later on in the presentation. I think this is something really worth thinking about at your individual center, and it requires a lot of considerations here for input of variables, because there's so many different things that drive cost administration. Pierre et al. Did a case control study looking at 5 veno-venous and 5 veno-arterial ECMO patients in 2013 using APTT to help titrate. And what Pierre et al. Found was a reduction in the adjustments in dose and a reduction in the time when the patients were in the supertherapeutic range. They didn't actually identify any major differences in other outcomes, including hemorrhage or survival. In 2017, Sanfilippo et al. looked at a total of 8 publications, 5 of which were case reports in a systematic review. The overall number of patients that you can see here on the slide is quite modest, and a portion of these, of course, were heparin controls. But I think the take-home points from this particular manuscript is a typical expected dose response or amount of the drug that you have to administer to achieve systemic anticoagulation. And it ranges 0.1 to 0.5 milligrams per kilo per hour. It's very uncommon to need doses above this. And you can really use a variety of different assays that are sensitive to the effect of bivalirudin to help titrate, including APTT and ACT. I would urge caution for the use of thromboelastography or other viscoelastic assays because they do not appear to have a lot of sensitivity, and their correlation coefficients are quite poor. Netley et al. In 2018 did a retrospective analysis of 8 ARDS veno-venous ECMO patients and 3 veno-arterial ECPR, ECLS patients. And really what they were looking at is just describing how they used bivalirudin clinically and their dosing protocol. They were able to achieve therapeutic range in all patients within 24 hours. Also that same year, Bieri et al. Looked at 44 cardiogenic shock patients, and 92% of these ended up on veno-arterial ECMO. As expected. And what they identified was no change in thrombotic events or mortality. And although this doesn't suggest superiority, it does suggest that bivalirudin may be a viable alternative. In 2019, Walker et al. Looked at 12 veno-venous ARDS patients and 2 post-cardiotomy veno-arterial ECMO patients. And they really just looked at the initiation of CRRT, renal replacement therapy, and they had to, of course, increase the infusion rates of bivalirudin to maintain appropriate therapeutic intensity. Goswami et al. Did a review looking specifically at pediatric cardiac surgery using bivalirudin. A little bit different population, of course, than ECMO per se, but what Goswami et al. Found was that it does circumvent a lot of the classical problems associated with heparin, but it comes with its own unique challenges, which sort of brings us to the COVID era. And I think this is where things start to pick up speed in the quality of evidence. Beginning in 2020 with Hamzah et al., this was published in Pediatric CCM in 2020. Really looking at an equal cohort, 16 heparin and 16 bivalirudin patients. 92% of these were veno-arterial ECMO patients, and there was no difference in survival between these two groups. But the bivalirudin group did have a reduction in bleeding and a reduction in the time to therapeutic intensity. And perhaps most importantly, actually, an overall reduction in cost of administration. And I wanted to dig into this just a little bit further. This is a slide taken directly from Hamzah et al.'s manuscript. And you can see here this heparin, this is highlighted in orange, and the bivalirudin highlighted in green. If you look at the cost of the bivalirudin and the cost of the heparin, clearly bivalirudin is significantly more expensive. But you don't have to use a more expensive assay, the anti-10A. You also don't have to use antithrombin assay, and you don't have to consider replacement with antithrombin. And if you look at the overall cost of administering this anticoagulant therapy, bivalirudin is less than half as expensive as heparin, at least in this study by Hamzah et al. In 2021, our group at the Mayo Clinic did a retrospective analysis over a 5-year window looking at a combination of adult and pediatric ECMO patients. About half of these patients were bivalirudin, and the other half were heparin-based therapy. And what we found ultimately was a marked reduction in mortality in those patients, the adult patients receiving bivalirudin, and the pediatric side, a reduction in transfusion requirements. And I wanted to, again, show just a little bit more detail. This is a lot of data on this slide. Let me draw your attention to a few highlights here. The far right is the adult patients, looking at 223 heparin versus 110 bivalirudin patients. And look at this hospital mortality. This odds ratio of 0.39, probably a bit too good to believe. There's a lot of variables that may have contributed to this difference in survival, including the temporal cohort being somewhat different. And yet this is very, very thought-provoking, and certainly it's been discussed quite significantly in the literature, particularly here in the last 6 months. As far as circuit interventions, there was not a statistical significant difference here, although I think this trend is worth noting with a p-value of 0.07, with bivalirudin having a reduction in circuit intervention rate. In the pediatric population, this is that transfused in the first 24 hours with a marked reduction in those receiving bivalirudin. Sheridan et al. In ASAIO in 2021 looked at 50 heparin patients versus 100 bivalirudin patients, again, all adults. And what they found was no difference in major bleeding effect, but in the bivalirudin group, there was an increased time within therapeutic range and a reduction in the time to achieve that therapeutic range. Secondarily, or maybe linked to these two findings, there was a reduction in the dose adjustments that were required to achieve systemic anticoagulation targets. Machado et al., again in ASAIO in 2021, looked at retrospectively over a 4-year time window. And these were in sort of sequential cohorts, initially heparin, 28 patients, followed by 18 bivalirudin patients, similar to the Ranuzzi et al. Style here. And what they found is that with those receiving bivalirudin, there was a reduction in phlebotomy-associated blood loss. Basically, they drew less labs. And also they found a reduction in mortality, which was quite significant here, 11% versus 43%. Now, the number of patients here is quite small. I did want to show you the survival probability curve, and this is taken directly from their manuscript. Notice the bivalirudin, this is the, on the y-axis is the likelihood that they're alive all the way out to 300 hours, so early in their ECMO run. And the heparin group has increased mortality, seems to be early in their run. Now you can see the p-value is 0.06. If you look at the entire length of their ECMO run, the bivalirudin had a statistically significant reduction in mortality. Rivosecki et al. In 2021 in CCM looked at a larger cohort, 162 heparin patients versus 133 bivalirudin patients. And they found that those receiving bivalirudin had less circuit thrombotic complications and really a grouped reduction in blood product transfusion requirements and a reduction in major bleeding. And these are all quite significant differences here between these two cohorts. I wanted to show you the probability of no clot. So that's the y-axis here. On the x-axis is the time on ECMO in days. And you can see some of these runs are quite long. But if you look here, the bivalirudin has a much greater likelihood of having no clot, extending all the way out to 75 days when compared to the heparin-based cohort. Lee et al. Published just recently here in 2022, a systematic review. Overall, they included just 9 articles. And when taken together, bivalirudin had a reduction in mortality, and you can see the odds ratios here, as well as a reduction in thrombosis. And in a pooled analysis, there was no differences in bleeding or circuit intervention rate. And so when you sort of gather all this information together, of course, it does call for nice randomized controlled trial or even just much larger retrospective studies. We're still waiting for those to come. But I think the overall accumulation of evidence is gradually in support of bivalirudin, at least as a viable strategy. I think I would like to recommend bivalirudin as an alternative first-line drug if your center is familiar with it, if you can develop the right protocols for safe administration. Certainly, you want to be able to use this drug, and it's indicated in patients who are receiving heparin and can get heparin-induced thrombocytopenia. If you're struggling with heparin resistance, and this is actually quite common in the neonatal and pediatric populations, an easier way versus replacing with antithrombin and doing all the assays is just to switch agents to one that doesn't require antithrombin at all. And we at the Mayo Clinic initially used bivalirudin for those with refractory fibrin or clot, and because we just deemed it to be overall superior anticoagulant. And I kind of wanted to spend some time talking about how that unfolded chronologically at our center, really how to operationalize the administration of bivalirudin in ECMO patients. Our guideline began in 2016, and it was based purely upon other people's work, particularly Ranuzzi et al. And Pieri et al., looking at a very intentionally conservative dosing strategy where we used a very modest quantity of bivalirudin, and we used multiple dose adjustments to get therapeutic. And we wanted to use this and have it available for patients with known heparin-induced thrombocytopenia. The second generation, 2018, we were able to use our own internal adult ECMO patients, and then we were able to develop and derive a renal dose table for starting dose, but also for adjustment in dose dependent upon estimated kidney function. And we added the how to handle low flow states, and we'll touch on that in just a moment. The third generation went live in 2020, and here we use a larger cohort, now over 100 patients, and we fine-tuned the dosing tables with a reanalysis. And then we added unique scenarios, including how to handle patients with phospholipid syndrome who are receiving PLEX therapy and another round of recommendations for administration in heparin-induced thrombocytopenia. Overall, we are now over 500 adult patients and 117 pediatric patients having received bivalirudin to date. I think it's important to have an algorithm. This isn't unique to bivalirudin. This is also true with unfractionated heparin. This is just an example of our algorithm. I'm not going to walk you through this. Each center that employs systemic anticoagulation for mechanical circulatory support patients should rely on some sort of scheme to outline its safe administration. This is just an example of ours. For bivalirudin, it's really useful to consider adjusting your dose contingent upon estimated kidney function. This is taken directly from our third generation guideline. You can see how we have patients who are receiving continuous renal replacement therapy denoted separately from all other categories of estimated kidney function. For adjusting the dose in real time, it is contingent upon the deviation from target range. The further you are deviated from target range, the greater the adjustment in dose. And also, the greater the adjustment in dose also ascribes the frequency of APTT monitoring. And we de-escalate that intentionally over time once stability is achieved. Our experience, one thing worth noting is that if we tried to individualize bivalirudin dosing, although we thought we were doing it well, we weren't when compared to those who were protocol compliant. Looking at those that were protocol compliant with bivalirudin, we had an 80% reduction in the time to APTT achievement for appropriate intensity. And the number of times that we had to adjust the dose was reduced by 60%. Just to touch on a few more implementation considerations, you need to know when not to use bivalirudin. This isn't a perfect drug. We don't have that perfect center of that three-sided pyramid that I showed you. We just don't have that yet. And so you need to recognize when not to use it. And I think this is probably the most important reason not to use it. And this is denoting periods of stasis. What occurs with stasis is that you get local proteolytic cleavage of bivalirudin, and so you get local loss of anticoagulant effect. For example, this cardiotomy chamber, new bivalirudin is not delivered to that chamber when there's stasis. Bivalirudin is metabolized, and then you get clot to form very quickly. And this slide on the right shows very dilated chambers. And if you see spontaneous echo contrast, particularly if there's artificial valves, either a bioprosthetic or mechanical, especially mechanical, these patients are very prothrombotic. And so if you get local loss of anticoagulant effect as this drug is metabolized non-enzymatically or organ independently, then you are predisposing to a thrombotic deposition around those valves or within the lumen of these myocardial chambers. You need to have a carefully considered titration schedule, and that has to be also mindful of fluctuating renal replacement therapy. It's common that you need to cycle out a filter on your dialysis machine or go for a procedure where dialysis is held for a period of time. And how are you going to handle the administration of bivalirudin in those periods of fluctuating metabolism? You have to be aware of the nuances of the drug dosing. And just to draw your attention to a few of these, it does have a nonlinear dose response curve, particularly at higher doses. And so we have a cap on what we will therapeutically administer. If we reach that cap and we're still not getting a rise in APTT, then we'll use alternate assays. Specifically, we actually have the availability of doing bivalirudin concentration levels at the Mayo Clinic. INR interference, this is worth noting. When you draw an INR in a patient receiving bivalirudin or other DTIs, you expect to see the INR to be artifactually elevated. This is a reagent issue. It's not actually causing an increase in prothrombin time. It's just artificial in the laboratory assay itself. So don't be alarmed when you see the INRs come back at 1.3 to 1.5, which is the expected amount of elevation that you see with an appropriately anticoagulated patient on bivalirudin. Hemorrhage management, the way that we handle this is just to turn off the infusion. We have not had to administer any salvage therapies such as activated factor 7 or prothrombin complex concentrates. That has been described in the literature for other patients receiving direct thrombin inhibitors. We just haven't found the need at our center. For low flow states, particularly if you're going to clamp your ECMO circuit, you are causing stasis, even relative stasis with flows less than 1 liter per minute, and you have to worry about thrombosis. And so although it's acceptable in low flow, we add heparin as a continuous infusion if we get flows less than 1 liter per minute. We want to ensure appropriate intensity of anticoagulation at all times, and this is even more important when flows are low. And so once we get to that threshold, add the heparin, and then we draw ACTs every 15 minutes. And this is really to titrate the heparin effects, not the bivalirudin effect specifically. Last slide, just to draw your attention to some take-home points. It's essential to control thrombin. It's really your enemy for mechanical circulatory support. Recall that ECMO is a classic model of contact phase activation. And so systemic anticoagulation is essential. At least it usually is. There is some evidence that anticoagulant-free ECMO is possible, particularly with veno-venous ECMO patients, and also particularly if your flow is sustained greater than 2 liters per minute. Our circuits are getting better, the coatings are getting better, but for now, I think most of us feel comfortable saying with full certainty that systemic anticoagulation is appropriate most of the time. Heparin works. It's not that it doesn't work. It certainly does. It has limitations, though. The unpredictable half-life, the requirement to consider antithrombin levels for heparin resistance, the predisposition to heparin-induced thrombocytopenia. These are real clinically significant downsides to heparin-based therapy. Direct thrombin inhibitors are a viable alternative. The literature is maturing, and it seems to be able to achieve therapeutic range more quickly with less dose response adjustments, and may have a reduction in hemorrhage and secondary reduction in transfusion. The verdict is still out for mortality. There's now several studies, that ours included, that showed that reduction in mortality, and I think it really calls for urgency for future randomized studies to help settle whether or not bivalirudin-based therapy is indeed at least as good or perhaps superior to heparin-based therapy. And Dr. Hamzah and I are available for some questions. Thank you.
Hello, I hope you all had a chance to enjoy that presentation. Dr. Hamzah and I are here to help answer questions if you have any. Feel free to ask them verbally if you're able to. Otherwise, we've got the chat bar over here as well.
Mohammed and Troy, it's Mike Wall. Great talks. The question really for both of you is, when do you think we're going to go to bival as first-line therapy compared to heparin?
So I guess I can start fielding that one. I think already it is a fully viable alternate first-line therapy. Any center who looks at the data and feels that it's time to develop a protocol could feel comfortable employing it as first line. Our center for adults and pediatrics, that's what we do. And we only use heparin in patients who we feel bivalirudin is inappropriate. And it's really transformed our practice. It's simplified things greatly at the bedside on a regular basis. We are intervening upon our circuits far less frequently. We adjust our dose far less frequently. We've had patients supported for in excess of 9 months without changing the dose once. And we've de-escalated the laboratory frequency to every 2 weeks because it's that stable of a dosing regimen. And so I think it remains contingent upon some improved randomized data to say definitively that we should, but I think for now you can feel comfortable employing it as at least a viable alternate.
I concur with Troy. For example, our center has been using the bival for the last 5 years. We have very good experience. I think this is the time to do a prospective study, since I know that centers who have used bivalirudin have experience with that. There is no way they're going to go back to heparin. So I think if people are still waiting for evidence-based for using heparin versus bivalve, I think this is the time to do a prospective study. So hopefully in the next 1 year or 2, we'll have one that will convince, which way or the other to go with. But based on the evidence so far, it seems like it's very viable, it's very safe, it's cost-effective overall.
Well, sadly, we're still a heparin place, so we can be your control arm.
Heparin works well also. I think if you think about heparin, one of the things that needs to be explored or definitively settled is the use of antithrombin assaying and replacing. The literature is still tumultuous considering antithrombin replacement. And so I think it's a bigger question of bivalirudin or heparin. I think it's DTI versus heparin. And then the heparin category has some other nuances that need to be explored further. My hope is that improved assays will make bivalirudin even better in the future, just like with heparin-based therapy that was transformed with APTT and then sequentially to anti-10A and viscoelastic assessment. I think a similar technological advancements for bivalirudin titration may similarly improve its real-time administration. We recently went live with a bivalirudin concentration assay that was made available to us about now 6 months ago. And there should be some information in the literature here in the coming few months that describes this more thoroughly. But I think it may offer improvement in titration, particularly at the extremes, high dose and very low dose, which may make it even more beneficial to neonates and pediatrics. I see a question coming through the chat bar. It says, how do you manage VA patients on bivalirudin who need to go to the OR for transplantation? This is not all that uncommon of an occurrence at our center. The way that we handle all OR washouts or needing for interventions that are major and substantive, we just turn off the drug. The half-life is 25 minutes. By the time they realistically get mobilized by the anesthesia team, set up in the operating room, positioned and make incision, at least a couple of half-lives have already passed. And we just haven't found a need to actually antagonize the drug. Dr. Hamzah, do you have other thoughts on that?
Yeah, I do agree with you. If there is a procedure at the bedside, you can safely, I would say, half an hour would be enough to hold it. But for the OR procedures, you can turn it off maybe about an hour or half an hour before the OR procedure, and that should be sufficient. It's not going to cause bleeding in the OR.
It does not require the 4 to 6 hour hold like heparin does.
Sorry, this is Tim. Let me just clarify the question even deeper. No, yeah, turning off is easy. Like, hey, what are you going to do for bypass if they maybe are HIT positive or quote unquote heparin resistant? Do you guys have an anti-3 transfusion protocol for people who are heparin resistant? Or if you're HIT positive, how do you guys address that for people who need new valves, heart failure, things like that?
Like switching from heparin to bivalve?
Oh yeah, for bivalve to heparin, intraop, and things like that. I think that's one of the difficult situations is when we're on VA, ECMO, and you're like, hey, we're going to listen for heart transplant. Okay, how do we manage this? And it's always a difficult conversation. Sometimes we end up just bleeding a lot because that's what it is in the operating room.
So at our center, we have a developed very analogous protocol for bivalve administration during cardiopulmonary bypass for cardiac surgery. And so if they're already on bivalirudin and known to be HIT positive, we would maintain them on bivalirudin in the operating room during cardiopulmonary bypass. It requires a little bit of more nuanced approach, higher intensity frequency of monitoring and much more intense level of anticoagulation, but we don't change agents. We also have a protocol that's embedded within our 3rd generation guideline for transitioning between agents. So if we have to move from bivalirudin to heparin or vice versa, that's all built into our protocols. There's no question it's a very difficult task though. Although I don't have the data, anecdotally, they bleed a lot more on bivalirudin during cardiopulmonary bypass. There's just no question about it, they just do. And we can't antagonize it. So when you get to the end, when you want to come off anticoagulation, it's not done nearly as seamlessly as it is with heparin.
Agreed. I mean, that's kind of what ends up happening for us as well in Colorado is that they just bleed a ton intra-op, post-op, kind of like hopefully they come off VA post-transplant, and you just kind of transfuse until the bleeding stops, literally.
One of the things that we've noticed at our center is because of the popularity of bivalirudin in initially device patients, our cardiac surgeons request bivalirudin in most of their post-operative patients who require intravenous systemic anticoagulation until they can transition to an oral agent. So the vast majority of our cardiac surgical patients, they're not getting heparin anymore, they're getting bivalirudin. Other questions from the group? Okay, well, I think our contact information via email correspondence is available on the materials. Feel free to email Dr. Hamzah or I, or try and get back to you on a relatively quick basis with any questions that might come up. And I appreciate your attention and your questions.
Thank you, everyone.